Somebody need a hero?
Yes.
I think we need a hero.
Good Santa.
I like it. I like it. Is
Awesome.
that the name of the song?
Yep.
What is
My
it called?
skillet. Hero.
Hero.
Yeah.
That's a good one.
I can
think-
be your hero, baby.
Please don't ever do that again.
We are going to wait 1 minute before we start this and say happy anniversary, Mike.
Thank
to
you.
You and your wife. Wow.
Thank you. Thank you.
And bless her.
Wow, good for
Yeah,
you.
yeah,
Good
yeah.
for you.
Yeah,
Congratulations.
Yeah, so everybody make sure that they talk loud in
Okay.
this episode. We have the microphone here.
Okay.
We have the, we have the microphone here. Aaron is going to get us a microphone.
Please don't do that again either.
Right.
I'll get you a microphone.
Okay.
November webcast that actually releases on December the 1st. I know that sounds crazy, but that's just the way that it goes. The things that come about within the month, we talk about. Things EMS has been through. We're going to talk about some common cases that we might see around
Right.
Thanksgiving.
Mhm.
This one's called Thanksgiving Buffet. I'll get started.
And you've been vaccinated.
I have.
So that's why,
You're
that's why
proud
we can
of-
sit next to each
You're
other.
proud of me. You're proud of me.
Uh-huh.
Introduction. Welcome to Thanksgiving Buffet. We're sticking with the particular way that we do this is that we start out with a content corner. We go to a research roundup, interesting cases, and we then have closure. We have a guest on set today. We have Aaron Dix. He's the executive director at Prisma Health EMS. He has supported this type of education, been very good to us, has come in on his day off. Also, Fabiano in on her day off, and me and Tom are just always working. So,
No,
nonetheless,
I'll be at Greer at 3 o'clock.
okay. So come in on her.
No, I'm
day,
coming in
day.
early. Yeah.
All right.
Yeah,
so
you got it.
Something tells me she's going to be calling me around 6 o'clock because we
You
screwed
call
something
me.
up.
I do fast out. I'm like, I can't help.
So again, we'll stick with that
Okay.
particular format. When I actually applied for, which is some news. Let's go to current events and
Yeah.
announcements.
Yeah.
We now have all our social media linked to the website www.911in864.com www.911in864.com. All our Twitter account is linked, Instagram account is linked, and the Facebook account is linked. If you follow us on Facebook, subscribe to the website. You know,
Right.
it's easier to get that kind of information.
Yeah.
We had 4 submissions for CE credit,
Cool.
and we could do that now.
We can
We
for a
could do
whole
that.
year.
We could do that now for a whole year.
Somebody
it's a
thought
total.
this was good enough to keep going for 12
right.
months.
It's a total of 1 hour of CE credit, and the rules are you have to take the test.
Right.
You
The
can't.
test is not terrible.
No, it's actually very easy.
Yep.
Some of it's not even related to medical stuff. Some of it is
Right.
just something random that was mentioned within the
Right.
episode to make sure that
Yeah.
you actually watched the video. We have to
Right.
have a way to judge your engagement.
Yeah.
So that's big news that we have that. Let's see.
Oh, right. I think it's really important that Mike plus Fabs is for Facebook because I was just pulling it up and it's not there. So that's right. It's Mike plus Fabs
Mike plus Fabs
is
instead
the
of-
Facebook page.
okay.
Right, not 911 in the 864.
And the intern that
Right.
she manages all that, so
Yeah.
that wasn't
So-
really me.
Does she have a name?
She does. Her name is Ellie Dubose.
And she's amazing.
She is amazing. She created these slides.
Yeah, I know.
She's
We try to convince
she
her not
went
to be
out-
a physician anymore.
She went out
Stay
and
here
got
with you.
leaves and made those slides.
I bet you
That's
did.
how beautiful that is.
Yeah. I could. Her mom would definitely help her do that
Yeah.
activity. Yeah, she would.
First thing first, though, we're going to talk about Content Corner. I'm going to go through some of these things and just kind of bounce them off of you guys as you want to throw things out there. I'm going to talk about things that are important to me as an EMS provider, and then we can, when we get them and we bridge them into you, you talk about how you guys continue to manage that. But typically just stuff you see around the holidays, Thanksgiving type
Yeah.
stuff. Hypoglycemia, first off, obviously a condition involving low blood sugar, the diabetes. Sometimes we go in, we get a call for altered mental status or unknown problem. We get out there snoring respirations, patients sweating, that you might not get a good history. They may be there by themselves. They may second party that has no clue. You get out there, you start going through your diagnostic testing, and you get a blood pressure. Blood pressure is okay. Heart rate may be a little low. Sats are 92, 91%. Go ahead and throw them on some oxygen. Do a D-stick. You get 42. Immediately, you go ahead and start looking for lines, as they're unable to protect their own airway. Several ways that we manage that, if they are able to. And a quick question I always ask, maybe you have something different. Maybe you have something different, Aaron. One thing I always ask, just because the number definitely will surprise you. You've got people walkie-talkie 20, and then you've got people unresponsive at 53. I've never understood that. But when you get into this thing, I've always, when they're looking at me and they're just confused, I look at them and say, "Can you swallow?"
Yes.
Can you swallow? And if they nod their head at me, even if they are a little confused, that's when I start going to my oral glucose and type. But that's my key question. I always say, "Can you swallow?" What do you think about that?
I mean, I honestly don't even. What's the first thing like an ER doctor is going to be like? Oh, IV this and blah blah blah, unless it's not too bad, and then we're like tell them to feed the nerve. But I guess that makes more sense to do the "can you swallow" thing first. I mean, I think that would make it. Wouldn't that certainly would be effective?
Because just because they're a little confused doesn't mean they can't protect their own airway.
Right.
Doesn't mean you need to get, because we know that when we can get them to orally ingest something, that's typically going to sit with them.
I think you bring up a valid point though about the numbers. I would tell you that it all depends on where they're normally at, and I would say that we've had people called stroke alerts, and they're hypoglycemic like 150, and we're like, oh, it's 150. Well, if they're normally 300, and that's where they hang out all the time.
Some of you don't even think about.
Yeah, and then you're like, oh shoot, and then you give them D50 or you give them something to eat, and then they like magically their stroke resolves. You're like, oh, okay, that's something interesting to think about, right? We say that when we talk about shock, relative hypotension. It's relative hypoglycemia, right? But you're talking.
I like that term.
Yeah.
Relative.
Yeah, I think we're gonna be able to retire because we came up with that just now. Overall,
Aaron and Tom have been around for a good while. So they've seen the D50, they've seen the push from D50 to D10.
We had chem strips. We didn't have glucometers.
Yes.
So
they were little pieces of litmus
like
paper.
You would hold it
plastic.
up and it's like in a range.
Yes, it was 80 to
looks like
120,
they might be
120.
low.
Right.
Tell us what you're excited
That's
about with D10 versus D50.
Well, I would just say, going back to memory lane, we're just excited not to do the coma cocktail anymore.
Oh,
right?
I was just thinking that literally in my head.
Right. That's
you
why.
You mean the thiamine,
yeah,
glucose,
it was thiamine,
Narcan?
glucose, Narcan. Right.
Yeah,
because
we don't even have thiamine readily available
not anymore.
anyway. But.
Right. But yeah, you would have these chem strips, and you would have to. And the other problem with the chem strip is that they would smear. You had to get a drop of blood directly on both pieces of litmus paper correctly, and then it would have to sit for 2 minutes
Yes, you had to
before you
wait a
could wipe
certain
it
amount
off.
of time. If it went too long or not enough, it would not be accurate.
So I remember when we first got glucometers, and it was like the greatest thing on the face of the earth. Like, my God.
What's the time frame on something like that when you're talking about your chem strips?
It was 2 minutes. You had to wait a minimum of 2 minutes.
To get the blood and then wait 2 minutes.
2 minutes for a paramedic is...
Like a lifetime.
Yeah,
especially
it was crazy. Right.
Right.
Yeah. So I'm with you about the not eating thing, or being able to swallow and eat, but I'm also a little bit lazy, and diabetics who have dropped their glucose get nauseous. Yeah. So the opposing argument is you're going to be on scene for 45 minutes to an hour trying to get somebody to eat, and you're just fighting that. So I agree with you. If they can take it. But then also if you're like, you're sitting there constantly trying to shove stuff in their mouth, and they're fighting you, and they're nauseous, and you're like, their sugar's staying at 46, and you're like, you're going to be there for hours.
Or you do it as a bridging thing.
Yeah.
You're like, here, can you start eating this, and I'm going to look for an IV? Is that what you do? Is that
right?
What,
Right. Yeah. Because But you run those ones that at the same time every time they're not going to go, and so
and they don't need to go
Yeah.
per se. This is one of those things we've gotten kind of comfortable, especially when we start talking about mobile integrated health, about those patients who actually really need to go to the hospital.
Well, because there's a whole set of rules, though, isn't there, for like people that you're not supposed to waiver that are diabetics? Like if you opened the book, if you opened the EMS books that we study our exam from, it's like don't waiver the patient that has, and there's like a whole list of things, but you're like, that's probably most of them.
And also, are they by themselves?
Right.
Or is their family there to help them?
Right.
And in the D10 to D50 argument, to move on, that was out of necessity because you couldn't buy D50.
Shortages of D50,
You couldn't buy D50
Make sure
you
you
couldn't
speak
get sugar
loud.
water.
He's close to it.
I'm not loud.
I just want to make sure.
It's the first time somebody has said, Aaron, you're not loud. It's like more
it
cowbell.
had to come from me.
Right.
It had to come from me. All right,
so it came out of necessity about 10 years ago, but the literature actually shows that D10 is better than D50. They wake up more gradually. They don't get a spike in their sugar as much. There's no tissue necrosis if you happen to blow an IV with D10. You can stop it once they wake up. So there's actual literature to support the D10 over the D50.
Is that in peds and adults?
Yes. Yep.
And
Nifty.
they seem to come out of it smoother.
Yeah.
We used to have to restrain their hands, not because of being attacked.
We don't
just
think of this
want
at
them to
all,
hurt
right?
them.
Like, in the ER, we just don't think of it at all.
D10, they just kind of come out of it.
Yeah.
It's a little,
Makes
little
sense.
I mean,
more
you're
pleasant.
taking their sugar from 20, you're jacking it to 350
Right,
with
at
50
least.
cc's of fluid, right? And you're doing that over a period of a minute. And instead of D10, which allows them to just get smaller. I mean, it's the same amount of drug. It's still 25 grams of glucose.
One thing that we need to discuss before we move on, and I know, or I say I know, and maybe people that don't watch our episode as much as, but let's talk about why sometimes when I'm able to establish vascular access, let's talk about why glucagon doesn't work all the time, or why it's not as effective all the time. Typically,
if
it's like because of glycogen storage.
Right, but let's start with drunks. So anybody who's an alcoholic is not storing glycogen. You have to follow the Krebs cycle, and that the alcohol inhibits the storage of glucose. So if you have a hardcore diabetic who's also an alcoholic, glycogen, glucagon's not going to work at all. They didn't store it. And then if they didn't...
I'm just having hives from the Krebs cycle.
Sorry.
You brought it up and I'm like...
Yeah.
I like my throat just like instantly closed up. I was like something I wrote down and never want to remember
never
again.
Ever again.
No, I think that's a very valid point. The other thing, which actually we had an instance in the ER recently, you got to make sure to turn that insulin pump off.
Oh, or you'll keep driving the sugar down. That's brilliant.
It's like when you're like, of course
you're unconscious again. You might want to unplug the pump.
Of course I'll think of that, but no, you didn't.
Yeah.
And you just were like,
you
why
have
isn't this...
to stop it.
Right.
And the easiest thing to do is just pull the catheter out of the. Well, first of all, you could just pull the catheter out of the skin, or you can just disconnect it from the insulin pump. But interesting.
I can say that in a future training.
Yeah.
I can't.
It
needs to be.
Right.
Has to be.
You don't think about it, but it's the
training
truth. It's a true story.
But I will tell you that just an interesting fact that prior to 1924, every single diabetic died. Period. End of story. Insulin did not come out until 1925.
Endocrine's
my thing.
baby.
Yeah.
When I was in EMT school, you taught my endocrine life.
It's just interesting. We think about that hypoglycemia is one of our most common medical emergencies that we do, but prior to 1924, every single diabetic died.
Like we go pee on the ground and the fire
ants. Yeah, the ants. Not fire ants.
I listen.
But
now there'll be fire ants because there's no regular ants left. So moving on, we'll talk about hyperglycemia. This one means a lot to me. The reason why this one means a lot to me is we don't do much for it pre-hospital. We go in, and this is where we get to dump fluid. This is where we start to, pre-hospital. That's really our go-to. Is we get in line. They're thirsty. They've been peeing all over the place, and we go in. We do an EKG, rule out anything, and then we hook up an IV and we start dumping fluid on them. The other reason this one is very important to me is because typically hyperglycemia, we have the hyperglycemic patients, but then we have the ones that are hyperglycemic long enough to where they become acidotic, where they go into DKA. And the reason why that one is important to me is because I feel like if you are really on your tactics, you got that patient that's sitting there blowing off, their respirations have increased that much because they are acidotic. The first thing you think about is airway control. And you know what I'm saying? Like the body is doing what it's doing.
That's right.
But then we go in and drop a tube, and now we're ventilating
should
them.
avoid that at all costs.
So, but I see that happening.
Yeah, it happens all the time.
So I would actually take a couple steps back further. So, the primary thing to remember when treating DKA, right, is we're talking type 1 only. And the reason why that's important is that after your glucose is greater than 250, in a type 1 diabetic, you're technically a DKA. You're in the beginning stages of DKA. So where paramedics are used to seeing very large or very small numbers, and we get very comfortable with mid-range, right? So you can have an adult type 1 diabetic in DKA with a glucose of 300. It doesn't take much.
Yeah.
Right?
Yeah.
So now a type 2
diabetic.
diabetic.
Higher, but
No. Because at 250 metabolically, if you follow what happens in the body, at 250 your body is starting to produce ketones in a type 1 diabetic only. So with a glucose of 300 with a type 1, they can be in full-blown DKA, and it can happen kind of rapidly. With a type 2 diabetic, they run chronically high glucoses. Right. So that's the important thing. It's not insulin dependent or non-insulin dependent. Are they a juvenile type 1 diabetic? If so, a lower glucose, as long as it's greater than 250, they can be a DKA. The second most important thing to remember is that you have to look for the precipitating event. Most of the time, there's some sepsis, stroke, something, because if you think about what happens in the body, if they're taking their insulin like they're supposed to, why would there all of a sudden be a surge of glucose? And that's because they had a Sears response.
Yeah.
Right.
The other thing to consider, and I think you make a valid point about the sugar, the BGL, is that the lab and nursing and all kinds of other people they get super jammed about like telling you what their glucose. The glucose would be 3,000. Okay, like the glucose is critical. I'm like, what's their anion gap? What's their anion gap? What's their anion gap?
Right.
And there's no answer yet. I'm like, like that's like so for us.
That's the problem.
We're following the gap. And actually, if you look at like a DKA order panel, you'll see all the stuff of the insulin driven, blah blah, and then you see like D50, D10, and a whole bunch of other stuff at the bottom. Because at some point, their sugar is going to be like 200, and you're like, oh, do I stop the pump? No. You stop it when the gap closes. So when their gap closes, they're out of DKA.
Right. So we got to talk about that real quick because a lot of people don't get what the anion gap is. So when you run a Chem 7, when you run blood work, you're only looking at certain things. You're looking at a couple things that are positive in nature and a couple things that are negative in nature. You're not looking at the full spectrum. So you're going to have a bunch of negatively charged particles in your Chem 7. So what you're looking for is an anion gap greater than 12.
Yeah.
And then if it's greater than 12, it's typically either going to be one of two things. It's going to be a keto acid or it's going to be a lactic acid.
Right.
The greater the gap, the greater than 12, the more acidotic your patient has become.
Right.
And I didn't bring up like DKA, all hyperglycemic patients are going to. I just brought it up because the fact is when you have hyperglycemia, I do think it's something that we think about. Is the patient progressing,
or educating them, like they just ate a bunch of stuff, or they're on steroids, or they're this or they're that, and they're like, oh, my sugar's 500. Well, really, are you really
in DKA?
Do you really need to go to the? Should you really? I mean, could you just take a
bolus your insulin?
Right.
Take a walk around It's the hyperglycemia with the tachycardia, the tachypnea, right? All of those things that lead to that DKA diagnosis. But to me, what the most important lesson, in my opinion, is that you have to look for the precipitating event.
Right.
There's going to be. It doesn't mean that there is
UTI.
But, there's a sepsis that's occurring,
something.
or there's a STEMI that's occurring. There's a stroke that's occurring. Yeah. Something has caused the body to release glycogen stores, to release additional glucose, that then pushes your BGL upwards.
Right.
And then in a type 1 diabetic, the pancreas cannot secrete additional insulin, so you end up in DKA. So you don't want to bring in a DKA patient and not treat the sepsis if it's there.
Right.
So something as simple as like abdominal pain could lead you right there.
Yeah. Yeah.
Before we move on, I do need to remind everybody, with it being Thanksgiving, don't forget to set your scales back at least 10 pounds.
That's right.
Season.
Your scales.
You get good food. Oh, Fab, send me that.
That's good stuff.
Yeah.
Assaults.
Oh, yeah.
For some reason, we think in the state of South Carolina, it's a good thing to bring everybody together right before the Clemson-Carolina game.
Yeah.
And it's always been that way. I mean, it's usually the last game we play, and sometimes it happens. I think every now and again, it might happen after Thanksgiving, but for the most part, it always happens before. And so you got football season. You may have a little bit of beverages that make you a little bit more, brave. And we can't ignore the fact that we run more assaults in the
Right.
Thanksgiving area.
And you'll have to
Or
think about
season.
who's okay to waiver then.
Right.
If they're intoxicated and got hit in the head. It's
So
not okay.
The key things that I think about with, obviously sometimes assaults, they're low acuity unless they go to Greer and they get
If I'm there, it's
punched
gonna
in
be
the
some
throat.
cool-
Yeah, that's right. That's
Right.
right.
It's gonna be some mess.
Ends
but-
up with the most
Right.
fantastic airway call ever.
Right.
But
Yeah,
pay
it's a
attention
disaster.
to your ones that got knocked out. Pay
Right.
attention to those
Right.
vital signs. They're vital signs for a reason. Pay attention to your vital
Right.
signs. Your complaint. I think that day your complaint was the fact of the hoarse voice.
Yeah, sore throat.
The sore throat. Pay attention to that kind of stuff. We do run more assaults in the holiday season. It's unfortunate, but we do.
Yeah.
But pay attention to the key things, the trauma criteria that should make you think that, this is not just our...
Yeah, and then of course I need to know the whole story.
Right.
It has nothing to do with anything, the reason that they're there. I just need closure on what happened. And I will find out what it is.
Oh, I know.
It's not going to matter. But
Tom,
anyway.
so, obviously I'm a South Carolina fan, you're a Clemson fan.
Mm-hmm.
Let's just keep it cool this season. Give Fabs a break. But by the way, I do want to say congratulations to both teams. They're both going bowling this year. So we're happy for them. This one right here, this was added from one of my co-workers that I didn't even think about, but psychiatric emergencies. You think about the little people, the older people that, they may or may not have been abandoned, and they're spending Thanksgiving, Christmas time alone.
Yeah.
And you don't understand. You take for granted that you have, a family to go home to, and you take for granted that that is what that's all about. But the people that don't necessarily have that mean something to me, because you do. You get those, and you'll go out, and you haven't seen this patient, and you've never seen this patient, and all of a sudden something
Right.
just hit. They've done this way for this many years, and now it just hits that they're sad.
And they don't have to be. I mean, a lot of times this will come out because of large groups of people. This is the first time family members have seen each other in a long time, and you can push somebody to their mental breaking point. To me, if they're alone, it's easier to manage behavioral or psychiatric emergencies than in a house packed with people.
Sure.
Which, to me, the first thing that I do is I got to get them alone.
Clear the scene.
Right, I got to get them alone.
Clear it.
And it's less about.
Like get them to your truck or
No, I don't want them because you got to. They're not. You get these two groups of psychiatric patients or behavioral patients. If they're really compliant and they want to get out of the house, by all means, let's go. But most of them, especially when they're around people, don't want to admit it. They don't want to go to the ambulance. It's get them and everybody else has got to leave. You got to clear the room. You got to get everybody else out. And the other thing that kind of sucks is that the cops end up showing up.
Yeah.
90% of the time, if not
Does
more.
that make it better?
No, to me it makes it worse.
It always makes it
Right.
worse.
You
Nothing
got-
against the police. It's just
Yeah.
their way of dealing with
Right.
it is different.
It's different. They've got the physical presence. They're there to ensure safety. But then, think about it. You had a mental breakdown at the dining room table because your family was pressuring you or what have you. And the next thing you know,
Right.
you've got two big cops in your room, in your dining room. You got an ambulance showing up, maybe the fire department. And it's like, guys, just get everybody get out of the house. Let me just go to the front porch, go watch a football game. Just me and them. Let's just talk.
And that's kind of like a one-on-one
Just-
thing. And
right.
whoever gets the report,
Let's just get out.
it doesn't matter whose call it is. Whoever has the report, get with that
we should probably not fail to forget that some of these psychiatric behavioral emergencies would be linked to a medical problem.
Right.
So we don't want to just write it off as something, right? That's part one, and then part two is drug related.
Rule in, rule out type
Right.
deal.
We just got to forget. We can't forget that everybody's human.
Yeah.
You know, we get so caught in the constant turn and churn of our job that you just want to walk in. It's behavioral. It's nothing big. Get them to the truck, and instead you gotta actually have to just take a second, because there are people who have true behavioral psychiatric problems.
Yeah.
And pushing them is not good. You've got to get the temperature in the room down.
What I'm getting from that is that you want to listen.
Yeah.
Where all those things make it where you can listen to
Right.
them. Yeah.
And you got to lower the temperature in the room. That's what I try to do all the time, which is weird coming from me because everybody sees my energy. But on calls, most of the time, what I try really hard to do is just bring the temperature down. Just, all right, it's okay. We're here. It doesn't matter how complicated it is. We're not going to let anything bad happen. Let's talk.
Yeah.
So, really, in all honesty, that's it for Content Corner. We just want to throw out some emergencies, that we typically run a little more within this season, and just be prepared as providers. So what we'll do now is take a break, and we're going to go into Research Roundup. We have two things we're going to talk about. One, we have our first email.
Oh, that's
our first email, and believe it or not,
it wasn't hate mail.
It wasn't hate mail.
This is amazing.
Well, it was kind of directed at me, so it is.
Oh, this
somewhat,
is getting even better.
Yeah, it is somewhat.
Okay.
We're gonna present a hack, and we'll do our email mail sack. We're back with Research Roundup. We're gonna do two separate things. We're gonna do one where the email that we received, I'm gonna go ahead and read it out loud. Aaron Dix is very involved in this email, so it's good that he's here today.
Woo-wee.
This is titled Paramedic Student View of RSI. You may or may not remember this. I know I haven't really read this to you just yet, but I did send it to you to kind of jog your memory. First and foremost...
Well, hold on a minute before you read it out loud. You read it? I have really bad self-esteem. I don't need you reading this out loud.
I think you're okay. I could see.
Okay, all right.
I've been reading. I think you're good. You're in a good place so far.
Oh, yeah, you're good.
I won't have to edit
all right,
it.
No, you're good. I get what you're saying. No, you're good.
Yeah.
First and foremost, I hate that I cannot be there today to share this experience I had with an RSI in person. I was honored to work alongside of Aaron Dix during this high acuity call, and very thankful that he was there to assist the crew. I was riding with as a paramedic student that day. This particular call was very eye-opening to me. I didn't realize while I have been practicing scenarios with airway management on the airway mannequins during labs, what may seem to be just small steps, how easily they are overlooked, but how important they really are. Maybe it's just myself, but I realized that the particular placement of all the equipment involved in an RSI intubation, or any intubation at that, makes this type of emergency call run so much smoother. I am not going to lie, I was scared that day. It was finally real to me that this was no longer practicing on an airway mannequin, this was a real person. As myself and the crew I was riding with walked in and observed the condition of the patient alongside with the vital signs of this patient, initially intubation was a thought, but realizing the MPA and VVM was not efficient enough to maintain the patient's airway, the reality set in with me that intubation was now what we had to do as providers to adequately manage the patient's airway. The steps taken seemed to take a long time, but in reality it was a minute of an amount of time. There was a lot taking place in these moments. The calm assurance the crew and Aaron had helped me to see that it is okay to slow down, think things through, communicate and designate tasks while working efficiently. I really learned a lot on this call with the small things that make an intubation run as smoothly as it can. I think this is where you're really going to like this. Lifting the patient's head 30 degrees. Placing the tube tamer under the patient's head. Pre-oxygenating the patient. Having your hyperangulated video laryngoscope on and ready. Having the biad on the patient's chest. The bougie ready and at hand with direct intubation equipment. Suction on and near the patient's airway. A secondary ET tube. Intubated capnography plugged in at arm's reach. stethoscope ready to confirm the airway. Drug dosages and names are confirmed with Aaron and all crew members. This medical timeout was the most important part of reassuring crew members agreed with the drugs and dosages used for the RSI, and there was no miscommunication while choosing the correct drugs and dosages. How everything, even what I thought were small tasks, came into conjunction with a successful innovation, I can say that I have learned so much with just one call. Successful innovation was the most important part, of course, but what made the innovation successful was the small tasks being completed and organized. I can tell you that I know not all innovations are the same, but I work as hard to be the best paramedic that myself can be. I know now how important the small steps that can easily be ignored or overlooked are. I also know even though you're scared, your adrenaline is through the roof, it is okay to slow down and take your time. It only takes a minute to take a breath and think these steps through. I know it helps tremendously. I am forever thankful for the knowledge I have gained from this call, the crew, and Aaron Dix.
Wow.
I think somebody paid her.
Yeah,
Nicely done. How long did it take your intern to write that?
Yeah.
Do
That's
you remember?
Well done.
I know this is very vague, but
No, I remember. I
okay.
don't intubate a lot of people anymore.
Yeah.
I mean, coming out of the office,
Yeah.
I don't intubate a lot of people, and the crew was fantastic.
Okay.
So
I had no idea there was a medical timeout done in EMS.
well,
Like we do it,
yeah,
but I had no
it's
idea.
rare. I like to practice what I teach because it's there for a reason, right? And part of it too is what's funny, and I told the crew this, was that I volunteered to go on this because the crew asked for RSI and there was nobody else available. So I was like, they're like, you don't have anybody. I said, I'll take it. And the whole way there, I was like, Aaron, you can't fuck this up. Like you can't invite yourself to the party and then
not come right
and then screw it up.
Right.
And but to me, it reminds me of Scott Weingart's series of using the laryngoscope blade as a murder weapon.
Yeah.
And I think what's really important to remember about this call too is this patient was not in the peri-arrest phase, right? So we had time.
Yeah.
Right.
That's right.
I want to make that clear because if you show up and you have somebody who's in the peri-arrest phase, you have what's called a crash airway, and that is different
That's
than
really not where you
what
wanna
we
be
have.
anyway.
Right. We don't want to be in that
Right.
space. In this case, when I get in the back of the truck, we have somebody who has no airway anymore. She is unresponsive, but still has a gag reflex. She's clenched, but her ventilations are no longer adequate. She can't control her own airway. But with a bag valve mask and a high flow nasal cannula underneath it, her oxygen saturation gets up to high 90s.
Mm-hmm.
She's not bradycardic. She's got a normal heart rate. I mean, so we're not in a crash airway situation. So the point is, yes, she without a shadow of a doubt needs an airway, but then how do you do it in a methodical manner so there's no error, right? And so when you're in the back of the ambulance, how do you manipulate that space? And I joked because I was at the gym thinking about this, and I'm not going to go with what I told you earlier, but right, I look at airway like dating,
Oh, yeah.
right, like the dating process, right? It's a process. It's not a skill. You can't just jam hard plastic down somebody's vocal cords and expect a good result. Somebody's going to get hurt, right? It starts with selection of the right patient, the right person, right? You don't date everybody that you run into at the bar. So, the next day I had to back somebody up on an RSI, got in the back and immediately said, we are not intubating her. She was 500 pounds, 5'4". She, without a shadow of a doubt, was, it was god awful how sick she was. And she was absolutely in the peri-arrest phase. But we were not intubating her. It was literally 2-hand bag valve mask technique, plastic in every orifice.
Yeah.
And ventilation, and we got her oxygen saturation up from 70 to just under 100, and then we just went to the hospital. This was past our ability to manage.
Yeah, and you'll call ahead and you're like, maybe you should have anesthesia there.
I told them that.
Seriously.
I called in. It was really funny because I said, "This is Aaron. I'm on Medic 101. I have a morbidly obese, impossible. It's going to be an extremely difficult intubation. She's in the peri-arrest phase. I'll see you in 7 minutes. You're going to need a lot of help." And I hung up the phone. I was like, that was
I
it.
would call anesthesia directly
Yeah.
immediately.
And yeah, so I mean, so the first part of it is to select the right patient. So when you get in the back of the truck and you look at her, and very quickly you're like, yes, you can obtain this airway. This is something that you can do. Right?
I think ER doctors forget about all of the OPA, MPA. Like we just have no, like we forget about that continually. And I'll tell you, every time it's a tech or the crew that brought them in, I was like, why don't you use it? And you're like, oh yeah, like you just, I don't know why we.
Do y'all confirm lung sounds too?
I mean, we listen, but I mean, in the days of cap, I mean, now with this,
Right.
now you just,
Right.
I mean,
it is
it's not quite the same, but I mean, yeah, you
Right.
should anyhow. But I mean, I just find it interesting because you're like, oh yeah, plastic in every orifice. I'm like, oh yeah, we always forget that. I mean, it's just not it's not a go-to, I guess.
Funny
But it
story.
makes sense.
When we transported a Ross patient. We got in. We had dropped a biad. We had dropped an eye gel. We get them in there. Patient starting, to bite, and vomit is coming up through the eye gel, and we're like, hey, we were like, literally, we could see your hospital. So we think the patient's probably going to need an ET tube, and we give our full report, and the doctor goes in and he intubates. He uses video laryngoscopy, great view of the cords. The paramedic actually helped him advance the stylet, the rigid stylet. Everything looked great, and I looked at the doc and I said, hey, you want me to confirm lung sounds? He was like, yes.
It's just stuff you don't think about anymore, and you're like, oh.
But with waveform capnography, it's without a doubt you want to, because you can be right mainstem.
Oh yeah.
Right.
Yeah.
And still have good capnography waveform. But in an RSI, I could care less what the lungs sound like. I want to know immediately, do I have capnography? Because you can get referred sounds. Somebody could be listening, the back of the motor, and you'd be like, hey, I hear lung sounds. But if you squeeze the bag and you don't see a blip on your cardiac monitor, and that's why I had the capnography already attached.
Yeah.
See, I do this as a very standard process. So as soon as the patient is intubated, right, and that stylet gets pulled, the capnography goes on, and then the bag goes on. Like, there's no...
Yeah.
So the first squeeze of the bag, they get 2 squeezes, and I'm looking at the monitor. That's it. I'm not going to hyperinflate the gut. I'm not going to, risk any of that.
Right.
It's 2 squeezes, and you will have instant blip, blip. And if that's good, all right.
But I
Now
didn't
let's
tell you
listen
the
to lung
funny
sounds.
part of that
Yeah.
story either. When I looked at him and said, would you like me to confirm lung sounds? I don't know where my stethoscope is. It could be anywhere.
Did you put your ear to the...
No. I said,
You look a
he
cup.
said, after he said yeah, I said, can I use your stethoscope? He gave it to me. Even in COVID season, he gave it to me.
Well done.
We're going to move on to, we'll take a short break, and then we're going to move on to the second part of Research Roundup. As I'm going to show you a quick hack, and then we'll move into interesting case. We'll be done.
Yeah.
Back with Research Roundup, I'm going to show you a hack that Fabs brought us.
Yeah, I actually listened to this on MRAP, and I can provide the link for it. We can put that on the website. But anyway, it was I thought it was pretty cool in the days of supply chain issues.
So this is how to make your own instant atomizer.
Yeah.
Okay.
That was a pretty good video.
Let me make that bigger.
That's wonderful.
Preview. Today I'm going to show you how to make an atomizer out of basic ED equipment. Background. Intranasal administration of critical medications is getting more and more popular because it's much faster than IM administration, and it's great for patients who don't have an IV. You've all heard of naloxone for opioid overdose, but some others include midazolam, fentanyl, ketamine, lidocaine, and even my personal favorite, haloperidol. The rate-limiting step in giving intranasal medications is getting the atomizer tip. A lot of departments don't stock them at all or keep them locked away somewhere where no one can find them in an urgent situation. Procedure. Making your own atomizer is easy. First, you just take an 18-gauge angiocath like this, and then fold over the plastic catheter like this. Wrap a narrow strip of tape around it to hold it down. Next, take an insulin syringe and poke one hole in the tubing. do it just proximal to the kink you made when you folded it. Try your best to align the needle from anterior to posterior along the axis of the angiocatheter, and not perpendicularly. Now screw the angiocath onto a 3 cc syringe containing your medication like this. You have to push pretty hard on the plunger for this to work, so it's difficult if you use larger syringes. The atomized medication usually does come out at a slight angle, but in the close confines of the nose, it doesn't really matter much because everything's just ricocheting off everything else. Put the angiocath in the patient's nose, pinch their nostril together to keep the medication from leaking out, and push the plunger hard and fast. It really works. And you don't have to wait until you have a sick patient to make these. Make them ahead of time and keep them handy for your next shift.
I love that.
Did you? I made one out of the.
Do you know all those drugs can go rectally too, right? Just pointing it out.
Yeah, that's what it's called. Look.
I actually wonder how they
We made
discovered
it.
that.
Yeah.
We made it.
You did good.
That's okay. When we're ready for those rectal administrations, we'll come back to the supervisor.
You did really, really good.
Now
but
let's
the
go
thing
get
is
one of
you gotta-
Aaron's children so we can.
But the thing
He
is,
needs to have Haldol if that's good. We're gonna do that.
Now
you
go
got to
sleep.
push really, really hard,
You do have
right?
to push hard on.
Yeah,
Hard,
but it's not
push hard.
hard.
It's not terrible.
Yeah,
Yeah.
it's not hard. The amount of resistance is similar to using an IO.
Okay.
You know, that's already been
You
flushed.
did good.
Well,
Yeah.
I tried.
We'll put the link so people can
Yeah.
watch the video.
And
Yeah.
you know, I would ask that everybody contribute 10 cents who watches this because we've used stuff we need to replenish our stuff.
I'll take
So-
it from Greer.
Okay, you take it.
Can we also need to sharpen that, right? We needed a smaller needle, but we still got the same
Yeah,
concept.
oh, it worked.
Yeah,
It
We
worked
needed
great.
a smaller needle.
Yeah.
It
Good
worked
job.
Thank you.
Strong
Thank
work.
you.
All right, we'll go into the interesting case, and then
Yeah.
we'll go to closure.
Yep.
In the
Okay.
words of Aaron Dix, let's get her done.
Yeah, yeah. So this is a case that we had this past week actually, and I thought it was really cool. What can you appreciate from these chest X-rays?
That you brought.
Thank you. What do you see?
I see AD pads. Or pacemaker.
Right, a pacemaker. Patients in the ER, so obviously something's going on, but this is the same patient. This is after their pacemaker was placed.
Oh, it's not where it's supposed to be. Look at that.
Right?
See, that was important. That's not the same.
Exactly.
the
It's
same
the
spot
same
to time.
patient.
Yeah.
And I'm like, and so my resident is reviewing this case with another attending, and they're
Wow.
looking at it, and they're going, this patient had some, palpitations and some other stuff, and they had a pacemaker placed here, and this is the other day, and they're looking, and we look for all the same stuff, right? Like, we're always like, okay, there's a pneumothorax, how does the mediastinum look? But we go through a whole series, and it depends on which way you do that. But, like, a lot of the time, you're like, yeah, there's a pacer, and, like, you move on. But this pacer is rotated, if you could appreciate it, this direction, and you're like, what? And so I say to them this, and I don't know how you advance to the next slide. This is Twiddler syndrome.
Are you ready for me
Yeah.
to go now?
Like, it has a name. And they're like, what do you mean? I'm like, this is tested, but it's super rare. Yeah, so it says they have pacemakers that last for years, but my phone battery lasts. I'm like, yeah, true story. But conscious or unconscious manipulation, it's almost always like somebody that keeps playing with this area, and it actually
It's
leads
okay.
to
One day yours
migration.
will be big too.
Migration, but here's the problem with it. This patient luckily didn't get to that point, but the leads can become dislodged. It can start stimulating the diaphragm and lose capture.
Yeah,
And it's called Twiddler syndrome, and it's rare.
that's really neat.
And when I saw it, I was like, I need to take a picture of this. Oh my god. So yeah,
So what did the patient come in with?
palpitations, and
Okay.
something was bothering them in here. And when they got the legitimately, but we actually got to write this diagnosis in Epic. I was like, you'll never write this the rest of your career.
How long
you have
has-
to write it.
Amazing.
How long had they had the pacemaker?
I think it was only like 2 months or something. It was a short amount of time, but people can do it.
Yeah,
like,
because they're sitting there.
They
playing
mess with it all the
yeah.
time. They always do. And I mean, we've seen like pocket infections and stuff, but like have never seen the standard Twiddler syndrome, which they test us on for our boards, even though it's rare. And I'm like, when I saw that this week, I was like, I've got to take this picture and put it on the podcast. 'Cause
So
this
they
is
did not aspirate any AED pads?
No, sir, they did not. No. But anyway.
This looks like a set of AED pads in the lungs.
Cool though.
It is really,
anyway,
really cool.
that was
Thanks
it.
for sharing. Twiddler syndrome. You
Yeah.
have we'll probably never.
So, I know someone would ask this. I know the answer, but I figured I'll let you do it. Let's say that this pacemaker is no longer working and their heart rate is 30. You okay with the medics
Yeah,
pacing them,
you
treating
should.
them as if the device isn't
should.
there?
You
Okay.
should.
I
Yeah.
feel like that's a really important thing because I think people get really scared when they see that somebody's got a pacemaker or have a defibrillator. If it's not working, you got to treat it as if it's not working.
Right, and actually you bring up a really good point and idea, Mike. We might have to consider doing some cardiac device lecture, because I'm going to tell you there's all kinds of, there's Impellas and LVADs and stuff, and then there's the latest literature that says you can do CPR
Yes.
and LVAD.
Yep.
And you should.
In order to maintain our actual schedule, we're going to follow like our NCCP model. This right here will fall under medical. That we will eventually get to cardiac, and
Yeah.
we can do that for
Yeah,
for
those
cardiac.
cardiac devices can be challenging. Because people don't know what to do with a magnet. Even doctors don't know what to do with
Right,
a magnet.
Right.
Or if
Everybody
you need
knows,
one,
give me a magnet. But
you'd
then
be
they're like, well, what do you do with it?
What are you doing with that?
Right.
What is your point? Yeah, so anyway,
Push-
I think that's a great
Push
idea.
paper clips
Yeah.
across the.
Did you know this is an actual true story? I asked somebody, he was hemorrhaging. I asked for a cat and got a cat.
You told me that the
I
other day.
actually got a physical cat. Like, what the hell am I supposed to do with
That
this?
would've-
Meow.
That would have threw me off. You know I'm a cat man anyway.
I need a
so
cat.
That would have
Yeah.
threw me off. Be sitting there and they give me a cat. Come here, buddy. All right, well that's good. I like that. I like the interesting case there. Twiddler syndrome.
Yeah.
That is
Conscious or
really
unconscious manipulation at the inflammation site by the patient with the result of device malfunction.
Lead dislodgement, diaphragmatic stimulation, or loss. Done.
No mention of aspiration of AED pads.
No, I'll let you write that case report up when it happens.
Boom! That
That
just
just
happened. We're moving on to closure.
Yeah.
We actually have a song that is relative. Go ahead.
Oh, I thought we were gonna,
Yeah.
you know, it's Jay-Z, Moment of Clarity.
Well
Right.
done. Good choice.
All right.
So we talked about a buffet of items that you may or may not see around Thanksgiving. We talked about
I'm gonna bet
hack.
May. I'm gonna bet May. Macy.
sure, May. You're right. We talked about a hack. Would love to hear more hacks, which may or may not be colorfully documented in your chart. We may have to talk about. We may document.
That
some of
was
those things.
really good. I love that.
Yeah,
I like that. And the fact that you put it together while the guy was sitting there talking. My favorite part of the video was
The shaking of the baby.
Right. There's some wilderness medicine hacks that you could actually do as well. That you would probably never put down in your chart, but we might be able to teach you those later. And then we talked about Twiddler syndrome, just because it showed up in the ER this week, and I was like, this is ridiculous. I have to take a photo. I
Amazing.
think it was Thursday.
Amazing.
That's a fresh case for you. And then what we do want to do though is we still need a logo, right? And we still need emails.
We have a temporary one that is on the webpage right now that looks really, really good.
Yeah.
I like
Matter of
I
fact,
like
Ellie
Yeah.
done that.
Good.
I think that's good.
And you know, as we get more submissions and more involvement, we've actually got some comments on the YouTube page.
Yeah.
Just a request to try to generate this into a podcast.
So you know what I'm gonna do? I'm gonna create a challenge coin.
a challenge coin.
Challenge coin. And you got right. Let's do that. I'll start working on it. Right. That'll be another way of supporting you guys, and you guys can hand them out when you get a cool case. Send us their address. We'll mail you
Let's send it to that paramedic.
a
station.
911 and the
We
864
will.
challenge coin.
Cool.
All right, I'll start working on that.
The paramedic student that submitted that, I will follow up. I have your information. We will send you a challenge coin. We appreciate you sending that to us. And also, we appreciate Aaron, coming in today and doing this. We appreciate the support.
Yeah.
We need a microphone.
I'll get you one.
Yeah.
If you don't get me
Yeah.
one, I'm going to...
Don't.
Oh, dear God.
I'll get you a microphone.
Okay.
So listen to our podcast, do the test so you can get CE credit. Submit us interesting cases.
This one, I'm really excited about this episode. I think that there was some great stuff talked about, and it's also festive.
It is.
This time
I'm
of
confused though because this is for next month. Like,
This
we have
actually-
Turkey Day coming, and I'm already dressing like Santa.
It's a good question. It's a good question. It's not the fact that I ignored Turkey Day, because I hate that. I hate that. I hate Thanksgiving stuff coming out before Halloween. You know what I'm saying? I hate
Yeah,
that.
here
The
we
reason it's a good question because all our episodes air at the beginning of the month.
Oh, you already said that.
All our
okay.
episodes air, and the fact that we haven't ate turkey yet, we can anticipate what types of calls we're going to run.
Gotcha.
That's right. That's right.
Thank
All
you
right.
guys for
Well,
coming.
Thank you.
Hit us up with that one more
Yeah,
time.
you got
Moment
that?
of clarity.
Moment of clarity.
We'll go out with that.
All right.
Anytime you
Go out
can
with that.
incorporate Jay-Z.
This moment of clarity, this moment of honesty, the world will feel my truth, but not like
Awesome job,
Good
guys.
job.
I love what you're doing.
Thanks, Tom.
Peace to your intern.
Thanks, Ellie. Yay.